So it's blood supply and lymph drainage of the limbs that we are going to discuss today. Okay. Then we will first talk about the upper limb. Um, so if you go to the upper limb, this picture is from Gray's Anatomy, the large book, not the student version. Now, this picture is a view from the posterior side. You can recognize by the spine of the scapula and many other things that are there to show that it's the posterior view. Now, in that diagram, you can see the arch of the aorta here, and this is the subclavian artery. In this case, is the left subclavian artery. Okay. Now, the subclavian artery, it's in the root of the neck. It is divided into three parts, which you will learn when you do the neck. It is divided into three parts based on its relationship to, there's a muscle. If you have the first rib like this, there's a muscle getting attached to the first rib, which is called scalenus anterior. This is the first rib. Subclavian artery comes out like this, behind, it goes behind the scalenus anterior, just like the axillary artery going behind the pec minor muscle. Now, based on the position of the muscle here in relation to the artery, it is divided into three parts again, like your axillary artery. So first part, then this is the third part, and the part behind the muscle is the second part. Okay. Now, when the subclavian artery passes distal to the outer border of the first rib, then it is called axillary artery. You know this. Okay. So in this picture, it's not very clear because it's a posterior view. You don't see the first rib as such very clearly. So maybe somewhere here, yeah, it says axillary artery. So it's somewhere here, it may be crossing the first rib. So then beyond that, you call it axillary artery. So that is one point that you need to learn from this diagram. Then if you continue the axillary artery, you get starting from the outer border of the first rib. If you draw your teres major, say if I draw it like this, teres major, if this is teres major, at the lower border of teres major, then the axillary artery, you call it brachial artery. Okay, so beyond that point, you call it brachial artery until it divides here, somewhere here in the cubital fossa. The brachial artery divides into its two main terminal branches, the ulnar artery and the radial artery. So its branches and everything we will discuss little by little. Certain branches I might miss. Okay, so it doesn't matter. Okay, take the big picture. Okay. So that is one thing. Then the other thing about this diagram is that you can see that it's not only the axillary artery that contributes to the blood supply. From the subclavian artery as a continuation of the subclavian artery, you can see some other arteries here in relation to the scapula. You can see certain branches arising from the subclavian artery. In this case, it's the first part of the subclavian artery. Gives branches, and these branches join the branches arising from the axillary artery here. You can see that. Okay, so these branches are coming from the subclavian artery, and these branches are coming from the axillary artery. So they join with each other. You call this anastomosis. Okay, so this is called scapular anastomosis. Okay, so this is called this area. You can see a very nice scapular anastomosis in the infraspinous fossa, that area. So we will discuss that also, which is an important thing. At least we question it a lot. So that's the other point that you can take from this picture. If we move to the next slide, now here this is a familiar picture. You have seen this picture in your dissector, I think. Now this is a very nice diagram of how you give these names. So it is subclavian artery up to the outer border of the first rib. Beyond that, it's subclavian artery up to here. Beyond that is the axillary artery up to the lower border of teres major muscle. Then beyond that is the brachial artery, as I said before. Then the axillary artery, based on its relationship to pec minor, is divided into three parts. The part above the pec minor, that is between the outer border of the first rib and the upper border of pec minor, some people call it medial border. Okay, but I would like to call it upper border. Then that part is first part. Then the part behind the muscle is the second part, and then the part below the muscle, that is between the lower border of pec minor and the lower border of teres major. That part is called the third part. Then from the first part, there is one artery coming out, superior thoracic artery. From the second part, there are two arteries coming out, two branches, thoracoacromial artery and lateral thoracic artery. Now, even though we call this thoracoacromial artery, it's not one artery. Sometimes you call it thoracoacromial trunk or acromiothoracic trunk, because it gives four branches. Okay, the four branches are, one is given to the clavicle, which is a clavicular branch. Then there is a pectoral branch, and there is an acromial branch and a deltoid branch. These are the four branches. Not that you have to remember all these branches. Sometimes people ask this, but this one becomes important later on because it contributes to the scapular anastomosis. Okay. Then the third part gives rise to three branches, two circumflex humeral arteries, anterior and posterior circumflex humeral arteries, and the subscapular artery. Now, when it comes to the anastomosis, scapular anastomosis, which we are going to discuss in the next slide, this becomes important. Subscapular artery, which is from the third part. That is the most important one, actually. To a lesser extent, this contributes through its acromial branch, as I said. Don't get this complicated, okay? And then the posterior circumflex humeral. Out of this posterior circumflex humeral also contributes, but the most important one is this one, subscapular artery. Okay, so this is your subscapular artery. So here's your subscapular artery is this one. This is your subscapular artery with its two branches, the circumflex scapular artery and the thoracodorsal artery. Here the circumflex scapular one is the most important one for the anastomosis. Okay. Okay, now this picture is to show you the scapular anastomosis. Now, if you go back to the previous one, again you can identify the arteries contributing from the subclavian artery, from the first part of the subclavian artery to the scapular anastomosis. Now, here this says deep branch of the transverse cervical artery. Okay, so that is in relation to the vertebral border of the scapula. And then there's another artery called suprascapular artery. They are coming from one single trunk, which is called the thyrocervical trunk. Okay, thyrocervical trunk. You will learn these things when you learn the neck. Okay, so that part you will learn later anyway. Then this is the other important artery contributing from the axillary artery side, third part of the axillary artery. So I said that one has two branches. One is circumflex scapular artery, which is here coming up here and anastomosing with the branches of the deep cervical artery and the suprascapular artery coming here, going around the spine and entering the subscapular, the infraspinous fossa, and forming an anastomosis here. Then this is the other branch of the subscapular artery, which is called, you saw it here, this one, thoracodorsal artery. Okay, so this is thoracodorsal branch of the subscapular artery. That also anastomosis here, you can see anastomosis with the deep branch of the transverse cervical artery. Now, this is an area, especially this one, deep branch of the transverse cervical artery, is given different names by different authors because there are variations in certain, certain people. But just remember this version. Okay, remember this version. But at the same time, remember that there are other versions of it slightly different from this one. Don't get confused. Okay, don't get confused. Okay, coming back to this picture. Okay, now this is the one which is called suprascapular artery, coming from the first part of the subclavian artery. And this is the vertebral border, remember. This is the lateral side. Okay. Then this is the deep branch of the transverse cervical artery. That is the contribution from the first part of the subclavian artery. First part of the subclavian artery. Then from, you don't see the subscapular artery as such, but you see its branches here. This is the circumflex scapular branch. The thoracodorsal one, which comes here, it's not drawn in this diagram. This is from a different book. Okay, this is from Moores, I think. Okay, so the thoracodorsal will come like this, which is also continuation of the subscapular artery as a branch. So that is basically, so you get the anastomosis here, especially in the infraspinous fossa. Then there is an extension to that anastomosis. There is an extension to that anastomosis. If I move on to the next slide, now here there is a branch given from the suprascapular artery, which is called acromial branch. It's the acromial branch. I have written it. Okay, acromial branch from the suprascapular artery. This one I am referring to. Okay, acromial branch. Shall I remove this? Acromial branch of the suprascapular artery. Anastomosis around the acromion with the acromial branch of the posterior circumflex humeral artery, okay, which is from the third part of the axillary artery again. Then acromial branches of the thoracoacromial trunk. Okay, that is from the second part of the axillary artery. So this is another extension. It's like an extension to the main scapular anastomosis. So if somebody asks you about the scapular anastomosis, so any question related to scapular anastomosis, then it's better to mention this extension also. You might not call it extension. You mention the first one, the main scapular anastomosis, this one, that is the most important one. Sometimes in the marking scheme, only this part can be there. Okay. But if the examiner wants, he can put this extension also, because anyway that's contributing to the main scapular anastomosis. So it's not difficult, just remember the whole thing in that way. So what the advantage is, having a scapular anastomosis, this is also called collateral circulation. The advantage is, if there is a block, say if there is a block in this area, if there is a block in this area, okay, it can go down to the second part also, because its main anastomosis is the third part. So anyway, if there is a block in that area, blood can, if you draw your scalenus muscle like this, if this is the first part of the subclavian, blood can flow from the first part of the subclavian artery to the third part of the axillary artery. As is I have seen, sometimes it can go to the thoracoacromial trunk also, through the acromial part of the scapular anastomosis sometimes. Okay, so this is the main one. Okay, so then the idea is this. So if you have a proximal block, there is always an alternative way of supplying the lymph. But remember the fact, if this block is very rapid, say if it is a sudden block, say you fall from a height and there is a fracture of somebody and the artery gets kinked like this, bent, and the blood supply stops suddenly, that will not, highly unlikely that the lymph will be saved if you don't immediately do something. But on the other hand, if there is a very gradual block, like in the case of an atherosclerotic plaque, how the formation of atherosclerotic plaques inside the blood vessels, you will learn when you do your pathology. So basically it's like this, we have a blood vessel like that. When you have high cholesterol levels, the cholesterol get deposited in the inner, the mucosa of the artery, and they become larger and larger over the years, obstructing the blood flow. Okay, so it's a very small area that you get to. Since it is gradual, there's enough time for these collateral vessels to open up. Okay, otherwise they remain very small because the usual blood flow is not through them. So in a gradual obstruction, these collateral vessels will open up, and you get a fairly good collateral circulation from the first part of the subclavian to the third part of the axillary. So in such a person, the limb is saved because of this collateral circulation. So that's an important point for you to remember. Then the other point that you need to remember is that both in the upper limb and lower limb, there are two or three important anastomoses, like the scapular anastomosis in the upper limb and the trochanteric and cruciate anastomosis in the lower limb. But that does not mean those are the only anastomoses that you get there. At all joints, around all joints, you take the elbow joint, you take the wrist joint, You take knee joint, ankle joint, all these places, there is some sort of anastomosis, okay, which you don't question you on because it's too much for you to remember. But remember the fact that there are anastomosis around other joints also, not only in the scapular or shoulder area. Okay, so this is basically the shoulder joint area. Okay, so that much is enough for the anastomosis around the scapula. Okay. Uh, as I said before, the brachial artery, it gives this profunda brachii artery or the deep artery of the arm, which is the one that passes with the radial artery in relation to the radial groove. You know that. Then the brachial artery continues down and divides into its radial artery, the two terminal branches, radial artery and the ulnar artery. Now, even though the diagram does not show it very clearly, the main artery, out of the two, the main artery, the larger artery is the ulnar artery. Okay, larger one is the ulnar artery, but then it gives another branch which is called the common intraosseous branch. Immediately after the ulnar artery is given off, it gives common intraosseous artery, which further divides into an anterior intraosseous and a posterior intraosseous artery. So you get the brachial artery like this, divides into radial and ulnar arteries. Okay, this is radial to the lateral side, ulnar to the medial side. Then this gives common intraosseous artery. It divides into anterior and posterior intraosseous artery. Now, these anterior and posterior intraosseous arteries, they lie on either side of the interosseous membrane. Okay, so that's why you call it anterior and posterior intraosseous. Now, the anterior interosseous artery, which is this one going in front of the interosseous membrane, it runs with the anterior interosseous branch of the median nerve, which supplies some of the anterior compartment muscles. Then the posterior interosseous artery, which you can see here, passes to the posterior compartment and runs behind the posterior the interosseous membrane. It supplies the muscles of the posterior compartment of the forearm, and it goes close with the posterior interosseous nerve. Posterior interosseous nerve is also called the deep branch of the radial nerve, which is the main nerve of the posterior compartment of the forearm. Then there's another point that you can see here. I think there's another separate slide also on that. You can see several other branches here. Here, superior ulnar collateral, inferior ulnar collateral, and anterior and posterior ulnar recurrent arteries, middle collateral, radial collateral, the interosseous recurrent and radial recurrent. All these arteries that I have circled, they are contributing to form the anastomosis around the elbow. So there's a fairly good anastomosis around the elbow joint. So that's why we said, in the previous lecture when we talked about Walkman's ischemic contracture, usually, due to supracondylar fractures as a complication of that, when you obstruct the brachial artery here or damage it, you, depending on the degree of the collateral circulation, the damage to the forearm muscles, the ischemic damage could vary. Okay, could vary. It's not 100% sometimes. Okay. Again, the same rule applies like in the scapular anastomosis. These collaterals are effective only when there is a gradual obstruction rather than a rapid obstruction like in supracondyle fracture. So the same rule applies. Okay. And the names of all these vessels you might not remember, but the basic rule is that if you look at these names, you can see there are two types of names, but it's not the same for all the places, but at least around the elbow, you can see the vessels, the small arteries that pass parallel to the main artery, and blood flow is also parallel to the main artery. Then they are called collateral arteries. Then on the other hand, there are small arteries which take origin from a main artery, and their blood flow is in the opposite direction from distal to proximal. They are called recurrent. Okay, they are called recurrent. So it's the collaterals that anastomose with recurrent ones. Okay, one example. Now here the superior ulnar collateral, as you can see here, anastomoses with the posterior ulnar recurrent artery. Okay, so from where they start and where they anastomose, you can, if you are interested, you can look at pictures and learn. I used to tell this to students, but The understanding in the department is that certain things are too much, when we go into too much of details, which is true. So I will not go into details of that. So you can go through this slide if you really want to learn about the anastomosis, so collateral circulation around the elbow joint. So all the vessels are listed here, the collateral ones and recurrent ones. Okay. Then, so this is a posterior view, the posterior compartment. This is to show you the relationship between the posterior interosseous nerve and the posterior interosseous artery, okay, which I just mentioned in the previous slide. Okay, so that's basically about that. Then as I said before, it's not only in the scapula or elbow area, even at the wrist, you see some degree of anastomosis of vessels. Now there you can see here palmar carpal arch and a dorsal carpal arch. So through these two arches, actually, you can see many blood vessels are anastomosing and forming a collateral supply. Okay, so which we will not go into details. Then I will use the same diagram to summarize, even though there are several separate slides, better to summarize it here. Now there are two arches in the palm area, superficial arch, palm arch, and the deep palm arch. Now if you look here, you can see the superficial palm arch is formed by the ulnar artery. You can see the ulnar artery, continuation of the ulnar artery. So this is continuation of the ulnar artery. So here it gives a deep branch, and continues as the main trunk of the ulnar artery. And the radial artery, on the other hand, you can see here radial artery. It sometimes gives a superficial branch here, this one, and it continues as the radial artery. So the superficial branch of the radial artery, I'll show you a different diagram later. Superficial branch of the radial artery with the ulnar artery forms the superficial palmar arch. And the continuation of the radial artery, which goes behind the thumb and comes back into the palm under the first dorsal interosseous here. Here, it unites with the deep branch of the ulnar artery, which is this one, deep branch of the ulnar artery, and forms the deep palmar arch. And through these palmar arches, they give certain branches, and they unite and form digital arteries to supply the fingers. Okay. Okay, so this is a better diagram of your superficial palmar arch. Now you see, now this is the thumb side. Okay, so this is the radial artery continuing around the thumb like that. Okay, behind it, and this is the superficial branch of the radial artery. Now this is the ulnar artery. This is the ulnar artery. This is the deep branch of the ulnar artery, going with the deep branch of the ulnar nerve. And you remember the Guyon's canal? Okay, so the vessels pass underneath that. And this is the superficial palmar arch. Superficial palmar arch. And this superficial palmar arch, sometimes this superficial branch of the radial artery is not there. I think in a fair number of cases, the superficial branch is not there. So the arch is formed, it's a half arch then. So arch is formed by the, so this part is not there then. Arch is formed by the ulnar artery then. Okay. So it's, in most of the cases, it's an incomplete arch, I think. Okay. The majority is incomplete, if I remember it correctly. Okay. Okay, now this is the radial artery coming here, going behind the thumb like this, and entering the palm again under the first. This is the first dorsal interosseous. Okay, this is the first dorsal interosseous. Okay, it's not adductopolysis. Okay, adductopolysis is deep to it. Okay, this must be the adductopolysis. Okay, so in the exam, if this is given as a spot, we give it very frequently. That's first dorsal interosseous. Okay, not adductopolysis. So the radial artery goes under that and into the palm to form the deep palmar arch. So what is this nerve then? This is the superficial branch of the radial nerve, which is a totally cutaneous nerve, and this is the one that forms the this area which is anesthetized if you if you damage, if you damage this, this may be the only area that will get anesthetized, because this area, even though you call it radial nerve supply, you will have a lot of overlaps from ulnar and median nerves. I told you during the last lecture. Okay. Okay, moving on to the next slide. Okay, now this one gives both arches, superficial palm arch and the deep palm arch. Superficial palm arch and the deep palm arch. One thing you can see is that the deep palm arch, when you look from front, it's proximal. It's proximal. Okay, it's proximal compared to the superficial palm arch. Okay, so the deep palm arch is formed by the deep branch of the ulnar artery and the continuation of the radial artery behind the tongue. Okay, and the two palmar arches give these branches, you give them different names. Okay, you can see the branches, they form common inclusive, yeah, common palmar digital arteries, and then the digital arteries. Okay, anyway, just remember that they give rise to digital arteries running on the lateral side of the finger. So in summary, you take a diagram like this. You might add the scapula also here, and then you can add the anastomosis. You have a diagram like this, a diagram of your ovum, and have it as a summary, okay, which gives the main branches and anastomosis. Don't go behind the anastomosis at the wrist. If you're interested, you can remember some of the things in relation to the elbow anastomosis, but not details. We usually don't ask too many questions from that area. Um, that's it. Then the venous drainage of the upper limb. Venous drainage. Here you can see, where should I start? You can see there is a dorsal venous arch on the dorsum of your hand. So that's the easiest place to start. From the lateral side or radial side of the dorsal venous arch, um, in relation to the anatomical snuff box area here, the cephalic vein starts. Cephalic vein starts, and it runs on the lateral border of the lateral margin of the upper limb, both in the forearm and arm. Then it passes through the delta pectoral groove here. So this is, you get the deltoid muscle here and the major muscle here. So between the two, you have a groove which is called delta pectoral groove. The vein passes, the cephalic vein passes through the delta pectoral groove. Then you have a fascia here between the clavicle and the pec minor, which is called clavipectoral fascia. You have seen that. So this vein, cephalic vein, pierces clavipectoral fascia and enters the axillary vein immediately before the axillary vein becomes subclavian vein at the outer border of the first strip. Same goal. Okay. So this is one thing that you need to remember. Then the other thing is, from the medial side of the dorsal venous arch, another vein starts, which is called the basilic vein. Okay, which is called the basilic vein, this one. So it runs on the medial border or the margin of the forearm and enters the arm and runs for a few inches on the medial border of the arm. Then it, if your deep fascia is like this, it pierces deep fascia and goes deep, and it enters the veins, 2 or 3 veins accompanying the brachial artery, which are called brachial vena committantes. Okay, vena committantes are deep veins. So the basilic vein pierces deep fascia of the lower part of the arm and enters the brachial vena committantes. And the brachial vena committantes, after entering the basilic vein, they are called axillary vein. Axillary vein. And usually the rule is just like the artery. If you have your teres major like this, both the artery, axillary artery ends there and becomes the brachial artery, and the brachial vena committantes, after the basilic vein enters, forms the axillary vein also somewhere at the lower border of the teres major. Okay, so even though the veins don't have a fixed rule, That is how it is described in many of the books. So you can take it like that. Then about vena comitatus, both in all both upper limbs and lower limbs, these deep veins are called vena comitatus. If you have an artery like this, a radial artery, ulnar artery, or brachial artery, you get two or three sometimes vena comitatus, and sometimes they have interconnections also between the two. Now, one importance is that this is going taking blood towards the core of the body. Arteries taking blood away from the core of the body to the periphery. So this blood coming from the periphery is the temperature is less compared to the blood coming from the core, the center of the body. So anyway, this temperature is going to be lost, and this one has to gain temperature. So because of this relationship, blood coming from the periphery through the veins get heated up. Otherwise, you will lose your body temperature by this peripheral blood coming in. Other thing is when the veins are like this, when the artery is pulsate, there's a pulsation in the artery, so that acts like a local peripheral heart like, and pumps blood. It helps to pump blood through the veins, because inside the veins you get valves directed towards the heart. So if you push it from the two sides, blood will only squeeze, only move in that direction, not in the opposite direction. Okay. So there are several reasons like this for having vena comitatus advantages. Um, okay, so when it comes to upper limb, the deep veins are not very important, but lower limb, deep veins become very important. Okay. Someone is typing. Right? Some books say cephalic vein joins with axillary vein. Some books say cephalic vein joins with subclavian vein, which is correct. Take it as axillary vein. Okay. So cephalic vein joins axillary vein at the outer border of the first rib and becomes the this is exactly the point that I mentioned. When it comes to veins, you can't say 100% the axillary vein starts at the lower border of the teres major. Even that is questionable. So the same rule, because in certain people the cephalic vein, it opens. The opening is just above the outer border of the first rib. So then you can't call it axillary vein. So then it's cephalic vein. So then different authors it's like Andayo telling the talking about the elephant. Okay. So one who feels the legs will describe the legs. One who feels the tail will describe the tail, and so on. Okay. Then okay, typing again. What is it? Okay, thank you. Don't say thank you. Okay. Then about the lymph drainage. Now, upper limb drains into axillary lymph nodes. Okay, upper limb drains into axillary lymph nodes, and the importance of axillary lymph nodes is not because the upper limb drains into that. Okay, that is also important, but why the axillary lymph nodes are so important? The reason for that is the breast actually. It's the breast here, especially in females, because the breast drains into axillary lymph nodes. About 75% of the lymph from the breast drains into axillary lymph nodes, and the breast cancers are increasing always. It's on the rise. It's one of the main cancers that kills people, and when axillary lymph nodes drain the breast tissue, it's very common to get secondary deposits, cancer deposits in the axillary lymph nodes. For that reason, axillary lymph nodes become important. Then upper limb also drains into axillary lymph nodes. That's a different issue. Now, axillary lymph nodes, there are 5 groups. There's an apical group, there's an anterior group, posterior group, lateral group, and a central group. Okay, this is not axillary. Okay, it's not axillary. So it's 1, 2, 3, 4, 5. Apical, anterior, posterior, lateral, and a group in the center of the axilla, which is called the central group. So all lymph, as you can see here through the arrows, drain into the central group from lateral, posterior, and anterior. Then from the central, it goes into the apical lymph nodes. And this, I will come back to this infraclavicular group of lymph nodes. Okay, so they are not considered axillary nodes, but they drain into the apical nodes, the uppermost group of axillary nodes. So having that in mind, we look at this diagram. This is a very diagrammatic representation of the axillary lymph nodes, but this gives you a good idea. Now, this is your clavicle on the right side, and now your axilla is something like this. Axilla is something like this. You have the floor, then you have the upper the apex here. Here it's the scapula. This is the first rib, and this is the clavicle. So this is the apex of the axilla. So the apical nodes are in relation to the apex of the axilla. So that is this one. Okay. Now the central group is embedded in the tissues in the middle of the axilla. Then the anterior group, it lies in relation to the, now if you draw, this one is the pec minor, lateral border of the pectoralis minor. This one is the lateral border of the subscapularis muscle. Okay. The pec minor is anterior, subscapularis is posterior, you know that. Okay. And that's how they are arranged. So the anterior group is arranged in relation to the pec minor, and the posterior group is arranged in relation to the subscapularis muscle. So then the lateral one, now this is the upper limb, lateral one is in relation to the axillary vein here. Okay, lateral one. So the anterior and posterior ones are here. Okay, central one is somewhere here, apical one is somewhere there. Okay. So if I show you something else, now this anterior group, if you look at the anterior group, that is not only in relation to the pec minor muscle, but the lymph nodes lie along the lateral thoracic artery. You remember lateral thoracic artery, which is a branch from the second part of the axillary artery. The artery runs in relation, if you have the pec minor like this, pec minor attached to the coracoid process, lateral thoracic artery runs like this. Lymph nodes are arranged along the artery like that. Okay. And this lateral thoracic artery again is an important artery, especially in females, because that's the main blood supply to the breast. Okay, from the axillary artery. Then the subscapular artery, is in relation to the subscapularis muscle here. Sorry, subscapularis muscle here, and the lymph node subscapular group of lymph nodes, you call it scapular group of lymph nodes also, posterior group, lies in relation to the subscapular artery there. Okay. And this anterior group is also called pectoral group because it's relation to it's related to the pectoralis minor. Pectoral group, this is called subscapular group. Subscapular group, you can understand that. Okay, because of this relationship. Then here, as I said before, lateral group is in the upper end of the arm in relation to the axilla, in relation to the axillary vein. And all these lymph ultimately drain into the, through the apical nodes. They can go into the supraclavicular nodes, which belongs to neck lymph nodes, or they drain into the thoracic duct directly or through the right lymphatic duct. Okay. So sometimes you get right lymphatic duct, sometimes you don't get it. Okay. Then lymph drainage of the upper limb. It's easy to remember lymph drainage of the upper limb. Now you have already learned about the lateral group of the axillary lymph nodes, and this infraclavicular group. It's not axillary nodes, but it's very closely related to axillary nodes. Now the medial side, that is this side, medial side of the hand and forearm. Okay, hand and forearm along the basilic vein. Okay, basilic vein is in that area. Along the basilic vein, drains into a small group of lymph nodes in the supratrochlear. You have the trochlea here. You remember the trochlea of the humerus. Above the trochlea, you have the supratrochlear lymph node group. So this lymph from the medial side of the hand and forearm drains into the supratrochlear group of nodes. And from the lateral side, superficial lymph. Okay, I'm referring to the superficial lymph here. From the lateral side, along the cephalic vein, it drains into the lateral group of, it drains into the infraclavicular group. Okay, infraclavicular group of lymph nodes. Okay, from the lateral side. And when it comes to deep lymph, all lymph from the deep structures will go into the lateral group of axillary nodes. Then from there into central and apical groups. And whatever that went into the supratrochlear group of nodes also ultimately go into the lateral group and continue. Okay, it's not very difficult thing. Okay, so they just drain into any lymph node that is on their way. Okay, so remember it that way. Okay, try to answer this. This is a straightforward question because we just discussed this. It says when the distal end of the subclavian artery is occluded, uh, so distal end means maybe the second or third part. Blood will flow from the proximal subclavian artery, maybe the first part, to the axillary artery through the following arteries. So suprascapular, thoracoacromial, circumflex scapular, lateral thoracic, posterior circumflex humeral. So except lateral thoracic, all other branches are correct. Okay, all other branches are correct. Then we'll move on to the lower limb. Now, the same thing, we'll go through the arteries and then the veins and then lymph drainage. Okay. Okay, now the gluteal region, thigh and popliteal fossa. It's disturbing now to have this popliteal fossa. Now, again, this is a bit complicated, but I'll try to summarize in at least some of it. Now you take it like this. Now you have the aorta. Okay, aorta in the posterior abdominal wall. These things you will learn later. Posterior abdominal wall. It divides. Aorta bifurcates. You call it bifurcation. Okay, that level is L4 lower border. Okay, aorta divides into its two terminal branches, the common iliac arteries. Okay, there are two common iliac arteries, left and right, at the lower border of L4. Okay, and the two common iliac arteries divides into, they divide into internal iliac artery and the external iliac artery in front of the sacroiliac joint. Now this is sacroiliac joint, in front of the sacroiliac joint. Then the internal iliac artery, this one, is the main artery that supplies pelvic organs, and the perineal organs. Okay, so the internal iliac artery has about 9 branches, especially in females, because they have the uterus and the vagina, so you get some extra arteries originating from that. So there are 9 branches typically. You remember it as 9 branches from the internal iliac artery, and some of these branches will go into the gluteal region, which, as you can see here. So these are branches of the internal iliac artery. So ultimately they come out to the gluteal region. Superior gluteal and inferior gluteal arteries that you have seen during a dissection are branches of the internal iliac artery. Then in the medial compartment, when you dissect the medial compartment, you must have seen, I don't know whether you have seen, it's all videos, obturator artery going with the obturator nerve, the nerve of the adductor compartment of the thigh. This obturator artery is also a branch from the internal iliac artery. So there are several other branches which I will not go into the details of. Then the external iliac artery on the other hand, passes posterior or deep to the inguinal ligament, and at that point, just like the axillary artery is formed, from the subclavian artery at the outer border of the first rib, the external iliac artery becomes femoral artery distal to the inguinal ligament. Then before it passes beyond the inguinal ligament, it gives few branches, okay, that supplies the anterior abdominal wall. Okay, it gives inferior epigastric artery, which is an important artery when it comes to the inguinal region. That becomes a landmark for you to identify medial and the direct and indirect inguinal hernias. You will learn that later when you do the abdomen. Then this is a branch that supplies the anterior abdominal wall. Then after it passes under the inguinal ligament, it becomes a femoral artery. As I said, the main artery of the lower limb. Then below the inguinal ligament, and the other thing is when it enters the lower limb with the femoral vein, it passes through a fascial sheath, which is called the femoral sheath, which is a continuation of the transversalis fascia and the iliacus fascia. Iliacus fascia is here. Okay, transversalis fascia is on the anterior abdominal wall in aspect. Now, anyway, we will learn these things later. So it passes to the lower limb through this fascial covering, which is called the femoral sheath. And while it is in the femoral sheath, it gives several branches, which are called, there are 4 branches. Okay, it's superficial circumflex iliac and the superficial epigastric. I don't know where it is. Okay, superficial epigastric, it's not drawn here. Okay, so superficial epigastric is going in that direction. Okay, towards the umbilicus. Superficial circumflex iliac, superficial epigastric, and superficial and deep external pudendal arteries, which are not so important, but those are the first few arteries that are given from the femoral artery. Then the femoral artery gives its profunda brachii artery, okay, deep artery of the thigh. So profunda brachii artery is also called deep femoral artery, I told you before, and the main femoral artery in that case, main femoral artery, if you call this deep femoral artery, then this has to be called superficial femoral artery. But anatomists use this, deep artery of the thigh for profunda femoris artery, and for this one we call femoral artery. But clinicians, especially radiologists, use this deep femoral artery and superficial femoral artery terminology. Then from the profunda brachii artery, then there are several branches. We will do that in a different slide. It's not very clear here. So the profunda brachii artery is the main artery of the thigh, and again in the knee joint area, you can see a very nice anastomosis there, with several blood vessels getting involved. Okay, then the other point is the femoral artery passes through the adductor canal here, and there is what is called adductor hiatus opening in the adductor magnus muscle. And beyond adductor hiatus, again the name changes. The femoral artery becomes popliteal artery because the popliteal fossa is in that area. Okay, then the popliteal artery gives several branches here, genicular branches, and divides into its two terminal branches, anterior and posterior tibial arteries. Okay, so these are the few branches that I mentioned that are given at the beginning of the femoral artery, the 4 branches. Then the deep artery, as you can see here, deep artery of the thigh or the profunda femoris artery, the 2 main. Yes, can someone mute yourself? Okay. Then the profunda femoris artery has it gives a branch which is called lateral circumflex femoral, and another branch called medial circumflex femoral. So the lateral one starts from the lateral side of the deep artery, and the medial one starts from the medial side of the deep artery. But their relationship to the femur is the lateral one is anterior, and the medial one is posterior. Then the continuation of the deep artery, it gives several perforating arteries, as you can see here, several perforating arteries. Then femoral artery passes through the adductor canal and deep artery and femoral artery. The adductor longus muscle is sandwiched between the two vessels. These details are not necessary for you. I think you know that already. Okay. Then this is a summary of the branches of the profunda femoris artery. I will not go into the details of that. I'll just skip that. Okay. Then this slide I showed you in one of the previous lectures. Um, in an arteriogram, when a dye is injected, this is the superficial femoral artery or the main femoral artery, and this is the deep femoral or the profunda femoris artery, which lies between the femoral artery and the bone itself. Okay. Then these two anastomoses, cruciate and trochanteric anastomoses, these anastomoses are out of the two, this is the most important one, trochanteric, because that is the main one that supplies the head of the femur. Now, how they are formed, if you can see here, you can see superior gluteal artery here, superior gluteal artery, and you can see the medial and lateral circumflex femoral arteries. So they anastomose and form the trochanteric anastomosis. The descending branch of the superior gluteal with the ascending branches of the medial and lateral circumflex femoral arteries. I think inferior gluteal is also involved in that. Just check whether inferior gluteal artery is also involved. Okay. I don't know whether I missed it here. Okay. So it's anyway between the superior gluteal artery, which is a branch from the obturate, which is a branch from the internal iliac artery. I told you before, a branch from the internal iliac artery anastomosis with branches from the femoral artery. So it's profunda brachii is a branch from the femoral artery. So the issue here is if you have a proximal block, like in the case of axillary, the subclavian and axillary arteries, if you have a block somewhere here in front, okay, to the femoral artery, to the proximal part of the femoral artery, blood can flow from the internal iliac artery to the distal part of the femoral artery through the profunda femoris artery, deep artery of the thigh, because of this anastomosis. Okay. Then the other thing is cruciate anastomosis. The trochanteric one is in relation to the greater trochanter here, that area. Okay. Cruciate one is in relation to the lesser trochanter, that is in this area. Okay. And that the anastomosis is between the transverse branches of the medial and lateral circumflex arteries and the descending branches from the inferior gluteal, which is this one, descending branches, which are these, and the ascending branches of the first perforating artery. So this is the first perforating artery. Okay, you can see the ascending branches going up like that. So that is the cruciate anastomosis. So that's it about the anastomosis. Then an important topic, blood supply of the head of the femur. Now, this blood supply of the head of the femur. This is an important discussion. Now, the blood supply. There are two or three sources of blood supply. Now, one supply is through the nutrient artery. Okay, it passes through the bone and passes through the neck, which is deep. So that is one supply through the nutrient artery. Okay. Then the other supply in children before puberty, and especially before the epiphyseal plate is closed, because you get what is called epiphyseal plate here. So before the epiphyseal plate is closed, closed means closed means the growth has stopped. Okay. So before it is closed, there's a branch from the obturate artery, again the internal iliac branch. Obturate artery passes through the ligament of the head of the femur and supplies the head of the femur. That is in children. In adults, this artery is no longer effective. It's not enough to supply the head of the femur. So the other important supply, especially in adults, is the trochanteric anastomosis. Out of the trochanteric anastomosis also, it's mainly it's the medial circumflex femoral artery through the trochanteric anastomosis that supplies the head of the femur. So in a child, you get this artery coming through this one, as well as blood coming from this side. Okay, so if there's a fracture of the neck of the femur, the head is not uh, seriously at risk because it has another blood supply. But in adults, this blood supply through the ligament of the head of the femur is very poor, or totally absent. Therefore, they totally depend on the blood supply through the neck of the femur, mainly through the medial circumflex, coming through the trochanteric anastomosis. Okay. Then how they are arranged is like this. Now you have the head here, then you have the neck. Okay. So you have this hyaline cartilage here covering this. Now if you have the acetabulum here, now the capsule, if you have the greater trochanter like this, you have the capsule coming here and getting attached to the capsule coming here, getting attached to the intertrochanteric line on the anterior side. And the fibers, I'm drawing on the anterior side, okay? And the fibers of the capsule are reflected backwards like this to this border of the hyaline cartilage, and there they are attached. These fibers are called retinacular fibers. These fibers are called retinacular fibers. And the blood vessels taking origin from the medial circumflex and the branches of the trochanteric anastomosis, they pass. Now if these are retinacular fibers are like that, blood vessels pass in between these retinacular fibers. Therefore, these vessels are called retinacular arteries. Okay, retinacular arteries. So they pass like that, and that is the main source of blood supply to the head of the femur in adults. And if you break the neck, if you fracture the neck in that area, that will damage the retinacular vessels, and the head of the femur is at risk because there is not enough blood supply. Then the other point is, now in front, the capsule is attached to the intertrochanteric line, but this is at the back posteriorly. This is called intertrochanteric crest. Line is in front, crest is behind. You can see the capsule does not come right up here. Okay, it falls short. It's attached to the neck actually here. Okay, then you get the retinacular fibers going up with the retinacular vessels in between. Okay, so if you have the capsule going like this, the synovial membrane also will go like that under that. So the blood vessels will be in between the retinacular fibers. Okay, so sometimes when they describe the retinacular vessels, they call them subsynovial. Subsynovial means if you look from this side, if your eye is here, if this is your eye, if you look from there, then it's under the synovial membrane, so you call it subsynovial. Okay, if you put a laparoscope or something into the joints, nowadays they do it, okay, and look at this, then it's subsynovial. Okay, so that's how you name it. If you read books only, you will find these issues. Okay, so if you fracture here, then the risk will not be there because the blood supply will be maintained, especially on the posterior side. If the fracture line goes like this, they are very safe. On the other hand, if you fracture here or in between or even here, then depending on the number of vessels damaged, the risk would be there. Then the branches of the popliteal artery, there are 5 genicular arteries. Now the middle genicular artery out of the 5 is important because it pierces the capsule of the knee joint posteriorly with the oblique popliteal ligament, and it supplies the cruciate ligaments, middle genicular arteries. Then the popliteal artery, usually the popliteal artery is, if your joint line is like this, knee joint line, It's a hand's breadth. I don't know how to draw it. It's hand's breadth above to hand's breadth below the knee joint. So hand's breadth is 5 centimeters. Okay. Hands are, they have different breadths. Okay. So it's 5 centimeters, about 5 centimeters below the knee joint line. Or you can call it, it's from the adductor hiatus. If somebody asks, the extent of the popliteal artery, these are the ways you can describe the extent. Okay. Either hand's breadth above to hand's breadth below, 5 centimeters above to 5 centimeters below the joint line, or you can say from the opening of the adductor hiatus to the soleal arch. So the soleus muscle has an arch like this, like flexor digitorum superficialis of the forearm. So that is the popliteal artery. Okay. So that's exact, Other measurements are very relative, okay, depending on the size of the hand. And okay, so these are the genicular arteries I mentioned: superior and inferior, medial and lateral. Those are the 5, and there's a middle one here. And then the 2 terminal arteries, the anterior tibial and posterior tibial arteries. Now the anterior tibial one, so your soleal, your soleal attachment is somewhere here. Okay, soleal arch is somewhere here. Then anterior tibial one passes to the front through the interosseous membrane and be the artery of the anterior compartment. Posterior tibial artery is the artery of the posterior compartment. Okay. Then this slide shows you the anastomosis around the knee joint. So you can see the vessels responsible. You don't have to remember all this. Okay, just remember that there is an anastomosis around the knee joint. Okay, so you can remember all this stuff. So this is, a summary of the vessels in the leg. Okay. So go through this carefully. The arteries I mentioned. Only thing I didn't mention was this one, peroneal artery. It's an important artery. It's the artery of the lateral compartment. It's actually a branch coming from the posterior tibial artery. You can see that it's branching off from the posterior tibial artery. It never enters the lateral compartment, even though it supplies the lateral compartment. It remains in the posterior compartment and sends branches to supply the lateral compartment. Okay. So if someone says popliteal artery lies in the lateral compartment, it's wrong. Okay. It supplies the lateral compartment, but lies in the posterior compartment. You can see this fact here. Now this is posterior tibial artery and this is fibular artery or peroneal artery. Okay. So then you can see it here. This is anterior compartment. Your fibula is longest and brevis. Yes, this is flexor hallucis is longest. Okay, so this is the lateral compartment. Okay, lateral compartment. So the peroneal artery is in the posterior compartment. It sends branches to the muscles in the lateral compartment. Okay. Then the anterior tibial artery. Now this is an anterior view. This is a dorsal side rather. Okay, so this is the dorsal side. This is the plantar side of the foot or the sole of the foot. Okay. Now the anterior tibial artery, when it crosses the ankle joint and enters the foot, then it is called dorsalis pedis artery. Okay, it is called dorsalis pedis artery. This one. Okay. Okay, it's called dorsalis pedis artery. So that artery supplies the foot. Details of it you don't need. Then on the other hand, the posterior tibial artery, okay, coming through the posterior compartment, it divides into a medial plantar artery and a lateral plantar artery. Medial one is a small one, lateral one is the main one. So the lateral plantar artery actually forms a the plantar arch here. Okay, it's usually, mostly it's an incomplete arch. Even though the medial plantar artery is there, it's too small to contribute to it. So it's from the lateral plantar artery the plantar arterial arch is formed. Then you get the digital branches as in the upper limb. Okay, so this is a nice diagram of that. So this is the lateral plantar artery, branch of the posterior tibial artery, forming the plantar arch. And the medial one is not big enough to contribute to it. Okay. Then about the superficial veins of the lower limb, superficial veins are more important when it comes to the lower limb, I think. And the superficial veins here, this is how you remember it. Just like in the upper limb, you get a dorsal venous arch on the dorsum of the foot, dorsal venous arch. From the medial side of the dorsal venous arch, immediately in front of the, nice, from the medial aspect of the dorsal venous arch in the foot, the great saphenous vein starts. Great saphenous vein starts. Then it runs on the medial border of the leg. At the knee joint, it passes 5 centimeters. Okay, 5 centimeters, so hand's breadth behind the medial border of the patella, behind this. Okay, and then in the thigh, it curves forward and comes to the front of the thigh and passes through the saphenous opening. Okay, and enters the femoral vein. Enters the femoral vein. So here this junction is called saphenofemoral junction, and there is a valve also there. Sometimes, people who get varicose veins, dilated veins of the lower limb, issue is sometimes here. The saphenofemoral junction, the valve is weak, so you get blood coming in the backward direction. Okay, so you will learn these are clinical things. Okay, so I'll discuss some of these things in this lecture also. Then from the lateral side of the, then this great saphenous vein, remember, it runs immediately in front of the medial malleolus. Okay, that's a very stable position. So if you cannot find any other vein in the body, this is the place to find a vein. Okay, great saphenous vein immediately in front of the medial malleolus. Okay, and the other point is that it accompanies the saphenous nerve. Okay, saphenous nerve here. Okay. And from the lateral side of the dorsal venous arch of the foot starts the small saphenous vein. Small saphenous vein, and it runs on the posterior side of the leg together with the sural nerve. Sural nerve is there, and it pierces deep fascia of the popliteal fossa and enters the popliteal vein. Okay, popliteal vein. So this is then the other thing is, now you remember the 4 branches given off from the femoral artery. Now there are venous tributaries entering the great saphenous vein with the same names. Okay, superficial circumflex iliac, superficial epigastric, superficial and deep external pudendal. Okay, because when you have incompetence here, there is a surgery called high tie. You tie the vein here. You have to tie these vessels also. Otherwise, this vein gets refilled, blood coming through them. Okay, so that's a little bit too much for you. Okay. Then another point. Now there are several tributaries to the great saphenous vein. You can see. Okay, these are all tributaries entering the great saphenous vein. But you need to remember an important tributary. Okay, so these are the 4 branches that I mentioned. Okay, joining. Then there is an important. These are other tributaries that enter it. An important tributary which is called posterior arch vein. That's a tributary, an important tributary of the great saphenous vein. Now, if this is medial malleolus, great saphenous vein lies immediately in front. Posterior arch vein lies immediately behind the medial malleolus. Okay. Now, why is posterior arch vein important? Because it has a lot of connections with deep veins. Okay. Now, when it comes to deep veins, I told you that in the upper limb and lower limb, deep veins follow arteries as vena committantes. Now, if you know the arteries, the same diagram that we used before, you can remember the veins. Now, these are the veins. Okay, so you have an anterior tibial vein and a posterior tibial vein, a peroneal vein opening into the posterior tibial vein. Then you have the popliteal vein and the femoral vein. Okay, that's how it is. Then if you add the superficial veins to the deep veins, where the deep veins are in black and superficial veins are in blue. Now I followed the diagram given in Chaurasya. Some of you read Chaurasya. Um, so I used that diagram. I read it, that diagram. It's a very nice diagram as a summary. Okay. So here you can see this is dorsal venous arch. Dorsal venous arch. From the medial side, you get the great saphenous vein, and the lateral side, you get the small saphenous vein. Small saphenous vein enters into the popliteal vein here. You can see that. And the great saphenous vein enter the femoral vein here at the saphenofemoral junction. Okay. And you can see other deep veins here, the posterior tibial, anterior tibial, and peroneal veins. And most importantly, the posterior arch vein, the tributary of the great saphenous vein. Now, there are connections between deep veins and superficial veins. Even in the upper limb, there are connections between superficial veins and deep veins, but we don't talk much about these things because you don't have many clinical issues related to it. But when it comes to the lower limb, these connections between superficial veins and deep veins become so important. Okay, so there are several places where you get these connections. Now here, if you have the knee joint here, above knee, above the knee, there is these are called perforating veins. Okay, there is a perforating vein called perforators connecting the great saphenous vein to the now this is above the adductor canal, so it's the femoral vein here. Okay, it connects the great saphenous vein to the femoral vein. Then below the knee joint, which is called below knee perforator, either the great saphenous vein or the posterior arch vein is connected to the posterior tibial vein. Then lower down, there are about three, these things can vary. There are about three medial perforators. Okay. One, in the lower part of the leg, and two in relation to the medial malleolus. I will not give you details. Okay. Otherwise, you will try to remember all these things. Then there's, usually there's only more medial perforators than lateral perforators. So there are several medial perforators you can see in the lower part of the leg. There's one lateral perforator usually between the peroneal vein and the small saphenous vein. And always these perforators are between superficial veins and deep veins. Okay. So the purpose is for the blood. I was supposed to have another slide. Okay. Anyway, you have your, say, if this is your deep fascia, I'll draw this deep fascia. And if this is your superficial veins here, okay, and if these are your deep veins, so the perforating veins will pass through the deep fascia and connect up with the deep veins. So when you walk, now these deep veins are located inside the muscles. When the muscles contract, deep vessels get squeezed. And if you look inside the deep vein, they have valves directed towards the heart. When this is squeezed from either side by the contraction of muscles, blood will flow towards the heart. And when the muscles relax, the other direction, when the muscles relax, then when this opens up, blood cannot flow backwards because the valves will close up. Okay. So what happens is when you walk and when you contract your calf muscles, blood will always flow in the deep veins towards the heart. Okay, if this is your heart, blood will always flow through the deep veins towards the heart, and they will never come back because of the valves. If the valves are good, okay, if they are defective, then there's a problem. Now, for this reason, this is called muscle pump, therefore. Okay, and it's mainly the soleus muscle that is responsible for it, and therefore you sometimes call it soleal pump. Soleal pump. And then what happens is when the blood in the deep veins, I'll remove this and draw a different one. When the blood in the deep veins are pushed towards the heart, pressure inside the deep veins drop when the muscles relax. And the blood in the superficial veins will be pulled into the deep veins through the perforating veins. Through the perforating veins. Again, valves in the perforating veins are directed towards the deep veins. So blood will flow from the superficial veins into the deep veins. Okay. And when the muscles contract, blood will not go back because these valves will close. Okay. But the issue here is when the deep vein valves are defective, for some reason, when the deep vein valves are defective, okay, then when the muscles contract here, blood will flow backwards through the perforator valves because they will damage the perforator valves also. and then blood will get collected in the superficial veins. Okay. Or when there is a issue somewhere here, again, it's between deep and superficial veins. If the valve here is defective, okay, even though there are no perforators as such there, again blood will flow from the the femoral vein into the great saphenous vein. Ultimately, when the blood gets collected there, what happens to the veins is that if initially the vein was like this, now the vein is like this, it's elongated, okay, and it's dilated, okay, it's larger now because the blood volume is high, and it's not only elongated now because it cannot stay in one place, it becomes like this. So there are 3 points. It's dilated, elongated, and tortuous. Tortuous means it has a lot of bends like that. Okay. So dilated, elongated, and tortuous superficial veins, especially in the lower lip, are called varicose veins. Okay. If somebody asks you what are varicose veins, that's how you describe it. Okay. Okay, so we have given questions, several questions about deep veins and superficial veins, and how the blood drains from superficial veins to deep veins, and about varicose veins in previous question papers. This is an area for you to study very well. Okay. Then about the lymph drainage of the lower limb. Now the lymph drainage in the lower limb is much more important than the lymph drainage of the upper limb. Okay. Now this is how you divide the lymph nodes in the lower limb. It's very easy. You have superficial lymph nodes and deep lymph nodes. Okay. So if this is your fascia lata, oh sorry, if this is your fascia lata, superficial lymph nodes are superficial to fascia lata. Deep lymph nodes are deep to fascia lata. So that's the basic thing. And the superficial lymph nodes are related to the superficial veins like great saphenous vein. And the deep lymph nodes are related to the deep veins like femoral vein and the popliteal vein. Anyway, now the superficial lymph nodes, superficial group of lymph nodes, you divide them into two groups. There is a horizontal group in relation to the inguinal ligament, just below the inguinal ligament. Then there is a vertical group in relation to the great saphenous vein. Okay, in relation to the great saphenous vein. And this, okay, now the two groups of lymph nodes we mentioned, the superficial group and the deep group. Superficial group lies immediately below the inguinal ligament. The horizontal part of the superficial group lies immediately below the inguinal ligament, and the vertical group lies in relation to the great saphenous vein here. And the horizontal group, horizontal part of the superficial group, can be divided into a lateral group and a medial group. Okay, so that's how you divide the superficial lymph nodes. The medial group is more important. It drains the anterior abdominal wall below the umbilicus, superficial limb. Then it drains the perineum. Okay, it drains the perineum. When you say perineum, skin of the scrotum, labium majus, then you get lower part of the anal canal, lower part of the vagina, all these things, plus the cone of the uterus. Now the uterus is like this. Okay, so there's what is called round ligament coming into this area in the females. So this through the round ligament, some lymph from the cone of the uterus also can come into the medial group of superficial inguinal nodes. Then the lateral group, superficial inguinal nodes, not very important. They drain the flank here and the buttock area. Okay, so this one is important. Then the vertical group of superficial inguinal nodes in relation to the great saphenous vein drains all superficial lymph except the posterolateral aspect of the leg, because that area is drained uh, through the lymphatics in relation to the small saphenous vein into the popliteal group of lymph nodes. Directly they drain into the popliteal group. Therefore, that part, the the posterolateral part of the leg will not drain into the vertical group. Others will drain. Okay. If you read this slide, you can see the summary of all the areas drained by lymph nodes. Now, when it comes to deep inguinal nodes, which are in relation to the femoral artery, all deep lymph and the lymph from the popliteal nodes, they drain into the deep inguinal nodes. And if you remember, when we did the anterior compartment, we said, the femoral sheath. Femoral sheath is like this. You have the femoral artery, you have the femoral vein, and you have the femoral canal here. Now the deep inguinal nodes in relation to the femoral vein, this is vein, deep inguinal nodes, upper end of that will lie in the femoral canal. And these nodes are called nodes of Cloquet. Nodes of Cloquet. I don't know whether I wrote it somewhere. Yeah, it's not here. Nodes of Cloquet. And they drain actually the glans penis in males and glands in males and clitoris in females. Okay, glands in males and clitoris in females. So those are the deep inguinal nodes in the femoral canal. Okay, so this I have mentioned. Okay, other things you can read from this one. Okay, then all lymph from the inguinal nodes, the superficial ones actually go into the deep nodes. Some do not go, but ultimately they go into the external iliac group of lymph nodes. External iliac group of lymph nodes. From there into the common iliac group, then into the para-aortic groups, because in the abdomen, the aorta is like this. Aorta has paired blood vessels like this from the sides and central blood vessels like that. So lymph nodes in relation to these lateral blood vessels are called para-aortic nodes, and blood vessels in relation to these central blood vessels are called lymph nodes in relation to the central blood vessels are called pre-aortic, pre and para. So these inguinal lymph ultimately go into para-aortic lymph nodes. Okay, para-aortic lymph nodes, and from there into this cisterna chyli, which is a sac-like thing, a few centimeters long, in relation to the L1, I think L1 and L2 lumbar vertebral bodies. So they all drain into that, and then even the lymph from the abdomen drains into that, and then it goes into the thoracic duct, which opens into the junction between the deep the internal jugular vein and subclavian vein in the neck. That's how the lymph gets into the bloodstream. Okay, try to answer this. Again, what we just did regarding the inguinal lymph nodes, medial group of superficial inguinal nodes drain a small part of the uterus. Yes, I said that. Vertical group of superficial inguinal nodes drain the dorsum of the foot. Yes, I said except the posterolateral aspect of the leg, all other leg. Deep nodes in the femoral canal drain glans penis. Yes, nodes of Cloquet. Nodes of Cloquet drain the skin of the penis. So this is the same thing. Okay, deep nodes in the femoral canal are the nodes of Cloquet. Okay. So nodes of Cloquet drain the skin of the penis. No, skin of the penis goes into medial group of lymph nodes. The Cloquets drain the glans penis. Okay, and clitoris in female. So it's the same thing asked in two different ways. All inguinal nodes final drain into internal iliac. No, it's external iliac. Okay.